All right, Doc. Thanks for coming again for the next episode. I think during the first one, you were telling us about the differential diagnosis. I mean, what are the potential causes of acute abdomen? And I think we had a very good time during the first episode. So now, welcome back to the second episode. And I would like us to do some drills or maybe some quiz, because most students do ask me about what could be the reason or the potential causes if a patient just give you the history without even performing the physical exam. And I said, okay, you can have a clue or maybe an idea about the condition, but before you can make a definitive diagnosis, you should go through the physical examination and then the investigations. But looking at the history part, I want us to go through some little or few drills or questions that if you have an idea about that, you can tell us so that the people out there can also have a clue, an idea when it comes to acute abdomen. Is that okay with you, please?
Yes, of course,
All right, thank you.
we can do that.
Thanks for your permission. All right, so what could be the reason or the cause when a patient comes to the clinic with abdominal pain, whether it is epigastric or whatever, it depends on the history or the location of the pain. But when the patient says, I have abdominal pain associated with vomiting and nausea, what do you think? What will come into your mind before even you do your physical examination and then your investigation? What do you think?
Um, that is a good question. If a patient have symptoms like the one that you just spoke about, we should be thinking about condition like pancreatitis,
Wow.
where where we have inflammations of the pancreas.
Wow.
So in order for us to confirm a diagnosis of that kind of condition, there are a couple of things that we have to do. For an example, we have to do the patient lab work, where we have to check out the uh, lipase level, that is the pancreatic enzyme level, the lipase amylase. But the lipase level is specific for damage associated with the pancreas.
Oh, wow.
So
That's good.
yeah, so basically we should be thinking about pancreatitis in
That
if a
in the
patient
first place.
have, yeah,
So
before
before you
thinking of
go,
other.
other
Mhm.
symptoms or other causes, right?
Yeah, yes,
Oh,
yes, yes.
right. So we should first think about pancreatitis before narrowing our mind on different other causes. I get it. I get it.
Yeah.
That's good. Right. So, what about somebody comes with and says, I have abdominal pain, and when I eat something, my food, the pain goes away. What do you think? Say I have abdominal pain, but when I eat food,
Mm-hmm.
it goes away. What should come into our mind?
Okay, that is also a good question. But just to add up for the first question that was being asked, okay,
Okay.
in addition to the nausea, vomiting, and maybe the patient is lack of appetite. In addition to all of those clinical manifestations,
Okay.
there will also be a fever. Yeah, there will be increase of the WBC count because this is an inflammatory condition.
Okay. That's
So
good.
yet, so of course, there's going to be fever as well.
These are there.
Now, so to come to the question that you just asked, now you said we have a patient, right, with
Abdominal pain.
abdominal pain, and then when he or she take in some food, the pain go away.
Yeah.
Yeah.
Yeah. That's the
So
question.
so um, in such a condition, we should be thinking about fatty ulcer disease, because basically um, we have fatty ulcer disease, we have a duodenal ulcer, and then we have a gastric, we have gastric ulcer.
Okay.
So for gastric ulcer, if the patient will have pain, like at the gastric pain, and the pain get worse with full intake.
Okay.
Yeah, that's gastric pain. And then for duodenal ulcer, that is where the patient may have sore in the mucosas of the duodenum. And if the patient take in some food, that alleviate the pain. Like,
Alleviate the
yeah,
pain. Wow.
yeah, alleviate the pain. So the question you just asked now, generally we can say it's peroxidase disease.
Because that is a wow. Wow. Thank you.
Yeah,
Thank you. So you just gave us I mean, distinction of gastric ulcer and then duodenal ulcer, but together they are all peptic ulcer, right?
yeah, all peroxidase, yes.
Okay, I get it. I get it. Thanks, thanks. Doc, what about if the patient comes and say, I have abdominal pain, and you measure the BP has dropped severely, like around 80 by 60 or 70 by 60, systolic BP 80, diastolic BP maybe 60, and then you check the respiratory rate and then it's hyperventilating, maybe 24, and then you check about the distance, the heart rate, and it's like almost 110. So what would be like? How the patient is tachycardic, the patient is tachypnea, having tachypnea, and then the patient is also having hypotension. What could be the cause? And then it's associated with abdominal pain. What could be the reason?
Oh, okay. If I can just quote you right, you I you spoke about a patient having an abdominal pain associated with low blood pressure,
Yeah.
both systolic and diastolic blood pressure.
Mm,
And this patient is also tachypneic, as well
mm,
as where there is increase of the respiratory rate.
mm.
And the patient is also tachycardic, where there is increase of the heart rate.
Yeah.
So in this case, um, we can say that the patient is hemodynamically unstable.
Unstable. Wow.
Yeah, yeah. So that may be a big term for somebody who don't have any
What
idea
idea? Okay.
about
Okay.
about
But
about about medicine, right?
but for the medical student outside, I think they will know.
Mm-hmm.
And then the premise.
Yeah, they are going to understand. So when a patient have condition of that kind, where the BP is low, in addition, the patient may even have confusion as well. The patient may be confused. So
Okay.
we say that the patient is hemodynamically unstable. So in such a condition, we may be thinking of maybe there is hemorrhage somewhere,
Okay.
the patient may be bleeding somewhere internally.
Mm.
So in this case, where it is associated with the abdomen, the patient have abdominal pain in addition to the low BP. So we can say that maybe the patient have bleeding within the GI tract.
Wow. Wow.
So we may be thinking of, for an example, let's say splenic rupture.
Okay.
You may be thinking of uh, ectopic rupture.
Okay. Especially in the
Yeah,
female,
so
in the
mm-hmm,
female patient, ectopic pregnancy. Okay. Okay.
yes, in female. And then we can also think of maybe there is a perforations. There is a perforation maybe anywhere along the GI tract that causing bleeding
Yeah, especially
as
in
well.
peritonitis. Yeah. Especially
Mm-hmm,
in the patient with
yes,
peritonitis. Yeah. Mm.
yes. So basically, if the patient is hemodynamically unstable, like in just the scenario that we just have,
Mm.
um, that that should make us to think about, let's say there is a hemorrhage somewhere, the patient is bleeding and stuff like that.
Wow.
Yeah.
Wow. That is perfect. So it should come into our mind. Probably this patient is in a serious condition. We
Mm.
should act quickly as soon as possible, right?
Sure,
Okay.
sure.
Right. Good. What about last question? Um, When the patient comes and say that I have abdominal pain and it's associated with constipation, and you take your stethoscope and you check for the bowel sound, and then it is diminished or reduced or even absent, what could be the cause? Tells you about abdominal pain, and then associated with constipation, and therefore you check for bowel sounds and it is being diminished, it's off,
Mhm.
or maybe absent or reduced. What could be the reason?
Okay. Right. That is a nice question.
Okay.
So, basically, just to clarify something quickly, what we are having, like the questions that we are like the scenario we're having is
It's
not really in an anxiety to like something as that happened. We are
okay.
just yeah, we are just discussing those things because these are common things that happen at times at the hospital within a
Okay.
clinical setting.
Okay.
Yeah. So if we have a patient with abdominal pain and
Constipation.
on auscultation, there is decrease of bowel move or bowel sounds.
Yeah, there's diminished
That
bowel sound or reduced bowel
yeah,
sound. Yeah.
there is
Okay.
reduced or bowel sound. So we should be thinking of and the patient is constipated as well, right?
Mm.
So
Mm.
that we should be thinking of maybe intestinal obstruction, bowel obstruction.
Wow.
That
Wow.
there is an obstruction anywhere within the bowel.
Wow.
So so that is the cause that causing the decrease of bowel movement. Let me say decrease of bowel movement or auscultation.
Wow.
Yeah, because the movement of food within the movement of food particle within the bowel is under the influence of peristalsis due to peristaltic movement and all of that. So if you have an intestinal obstruction, that is going to interfere with the bowel movement, with the peristalsis and stuff like that. So at the end of the day, if you do auscultation, there will be decrease of bowel movement or auscultation.
Wow.
So in such a condition, um, we can be thinking of bowel intestinal obstruction or bowel obstruction. And because the patient have bowel obstruction, that's why he or she is constipated as well.
Wow. Wow. Thanks. Thanks. So actually,
Yeah.
we should be thinking about bowel obstruction or intestinal obstruction when this
Sure.
uh, kind of symptoms and signs present to you in the clinic or the hospital floor. But I want to make this
Mhm.
clear to the people outside or the people watching us that all that we are saying are suggestions and then opinions and differentials that we have, and we want to just give it out to you so that you can also keep it. So, but you have to understand the principle of medicine that before you can diagnose a condition or a certain disease, you have to go through the ladder. You have to move from one step to another step. So, as we all know, we have to do our history, we have to take our complete history. Then we have to go through our physical examinations very clearly. Then we have to do our investigations. Then we can come up with a definitive diagnosis. That is the protocol, the thing that we should follow. The one that we are given here is a clue, idea, something that should come into your mind or you should be thinking about when such thing approaches you in the OR or the ER or the hospital floor or the clinic or whatever. You should be thinking about this thing. But remember to go through the protocols before you get a definitive diagnosis. So this is just a clue that Dr. Bamel is trying to give to us today about if such things happens, we should be thinking about not just a solid or confirmatory diagnosis that he's giving here. He's giving a differentials, potential causes. So please don't get us wrong, and I think you will get it very, very informative. And you can also bring your comments as you watch the video. Thank you very much, Dr. Bami, for such clarification. All right, so let's move on with
You're welcome.
to our management because now we've gotten to know their definition, the differentials, what could be the cause and stuff like that. And now we should move on to our management. So I would like us to separate the management into two folds or two different types. So the management could be a test and then, right.